Welcome to the Cardiovascular Emergencies lecture series where we're going to talk about acute coronary syndromes and cardiovascular diseases. We will also talk about other cardiovascular problems like diseases that are going to affect your arteries and things like that. All right, so let's talk first about the epidemiology of cardiovascular disease. First off, cardiovascular diseases are diseases that affect the cardiovascular system, the heart, the vessels, things like that. They are the leading cause of death in the United States. Okay, some of the examples here are angina, angina pectoris, which is chest pain, right? Acute myocardial infarction, or a patient has had a heart attack. Heart failure, where the heart fails to pump appropriately, leading to backflow. Stroke, which is an occlusion of a vessel in the brain that leads to poor blood flow, right? And then, or also could be a bleed within the brain. And then diseases of the arteries. These are things like peripheral artery disease, DVT, acute arterial occlusion, and things like that. All right, so the things we're going to talk about here are going to be the acute coronary syndromes. We'll talk about the etiology, the risk factors, prevention, the types of angina. We'll talk about acute myocardial infarction, and then the assessment and management. All right, so first things first, what is acute coronary syndrome? Acute coronary syndrome refers to any event that leads to either a thrombotic occlusion or plaque rupturing, causing symptomatic ischemia or infarction. It causes decreased blood flow or total obstruction of the vasculature in the heart tissue. And then you have to remember that when blood flow is disrupted through any artery, the blood or the area that is supplied downstream from that obstruction is going to become ischemic. Ischemia leads to injury, and if the injury is not corrected, infarction occurs, and infarction is death of tissue. Okay, so what I want you to see is when they talk about decreased blood flow, right, the first part of this would be an example of decreased blood flow, and this would be an example of, as you guys know, this here is plaque, right? And when plaque ruptures, it triggers the clotting cascade, and you get a clot that's going to form in this area, and this leads to total obstruction of the vessel. Okay, so with decreased blood flow, you can still have ischemia because there's less blood that gets to the tissue. With total loss of blood flow, then injury would occur, and then infarction would quickly follow without any intervention. All right, some of the things you have to know about atherosclerosis and arteriosclerosis. So atherosclerosis is the buildup of cholesterol and calcium in the blood vessels, leading to plaque formation. So what you're seeing over here in this picture is a normal human artery, nice and smooth, which is good because you get good blood flow, the lumen is nice and large, there's no turbulence through the vessel. And then to the right, you have atherosclerotic plaque, which is built up, this is going to be important, under the endothelial layer. So this builds up under the endothelium. Okay, all right. So atherosclerosis. And then you also have arteriosclerosis, which is the buildup of calcium in vessels that leads to less elasticity of the vessels. Okay, so elasticity is important for the vessels because without elasticity, they cannot accommodate well for vasodilation and things like that, right? So they also don't handle the turbulence of pulsatile flow as well, okay? Narrowing of your vessels leads to reduced and turbulent blood flow, and that turbulent blood flow is going to be important when we talk about plaque rupturing, okay? So when you have turbulence over that plaque, right, that's going to cause, that's eventually going to lead to plaque rupturing, or can lead to plaque rupturing, okay? So that turbulence leads to the plaque rupturing, clot formation occurs, and then the vessel is obstructed. So going back to the picture you saw on the last slide, if you want to rewind, you can. You saw the plaque at the top here. If this plaque were to rupture, right, the plaque starts to escape, and then you get platelets that come through here and occlude the vessel. And now we have total obstruction, okay, which means that nothing is getting through, and when nothing gets through, the tissue is going to die. All right. Just kind of in a different format for you, the etiology of ACS: arteries become lined with lipids, calcium, fibrin, and other cellular substances. Those substances damage the arterial lining, eventually causing a piece to break away, and bleeding occurs when you tear the endothelial lining. The inflammatory response initiates healing. The clot may break away and travel in the bloodstream, or it may stay right there, and then the artery is now significantly narrowed or occluded and unable to deliver oxygenated blood to meet cellular demand. And when we don't meet cellular demand, right, what happens? Tissue death, right? And this is also known as infarction. Okay. All right, your risk factors for acute coronary syndrome can be broken up into non-modifiable risk factors, things that cannot be changed, and modifiable risk factors, which can be controlled, modified, or treated. In general, things that are considered non-modifiable: your age, we have not figured out how to age in reverse, okay? Sex, race, okay? These are things that are non-modifiable. Modifiable risk factors are things that can be controlled, modified, or treated. So we could say lifestyle, right? How active are you or sedentary are you, right? Diet, medication compliance, etc. Okay, so again, remember that these do occur on a spectrum, and sometimes it's easy to say, oh, well, those are things that we can modify, but in reality, they may not be as easily modified as we would like to believe. This gives you an example of some of the things, the health disparities that are driven by social and economic inequities. So again, when we talk about those risk factors and things that are modifiable and things that are not, we think about diet, right? But if you come over here to food, some people don't have food security and they don't have access to healthy options, right? It's easy to say go out and walk, okay, but if you live in a city where there's a lot of crime and there's no sidewalks and it's dangerous, right? How much exercise you're going to be able to do, you're trading off potentially your safety for walking outside. Okay, so keep those things in mind. We think about, oh, well, they're non-compliant with their medications. Well, what if they don't have healthcare coverage? What if they can't get to the pharmacy? Okay, so those are some of the things we consider. Continuing with our risk factors for acute coronary syndrome, some of the common risk factors: diabetes, okay, diet that's high in saturated fats, trans fats, cholesterol, hypertension, and I'm going to put a star by this because to a point, some of these are modifiable, right? Obesity, okay, lack of physical activity, excessive alcohol, and tobacco use. Everything on this side is modifiable to a point. Now, what I will tell you about diabetes is like type 1 diabetes, you can control it. Type 2 diabetes, right? You can try to prevent it and then control it, right? And then hypertension, same thing. If you're diagnosed, you can try to, change your diet, change your weight, right? So some of these are modifiable, but again, just to a point, right? So tobacco use, definitely modifiable. Alcohol consumption, modifiable, okay? Family history. You don't have any control over what your family does, but if you have a parent or sibling who develops heart problems before 55 years old in men or 65 years old in women, that would be a risk factor for you for acute coronary syndrome. As your age increases, okay, as we get older, things don't work as ideally as they did before, so that's going to be a risk factor. And then your race, so it is the leading cause of death in the U.S. for African Americans, American Indians, Alaska Natives, and Caucasians. Okay, so these are things that you don't necessarily have control over, so we will say non-modifiable here. All right. What factors reduce the risk of cardiovascular disease? So there's several of them. Being aware, okay, of the signs and symptoms of cardiovascular disease, and being aware of your overall health, right, and what you can do to prevent. So awareness, behavior modification. So if you're using alcohol, tobacco, or you are not exercising, right, then we can modify those behaviors. Blood pressure control. We can also add stress management to that, but blood pressure control. So if you've been diagnosed with high blood pressure, making sure you're compliant with medications, cholesterol management with diet, exercise, medications, diabetes management, same thing, and then limit alcohol. Other things, lipid management, regular exercise, stopping smoking, managing your stress, and then weight management as well. So these are things that will help reduce the risk of cardiovascular disease. All right, we're getting into the types of cardiovascular acute coronary syndrome. So the first thing we're going to talk about is angina pectoris, okay, which is chest pain, right? So this is the principal symptom of coronary artery disease. It literally means choking of the chest. So angina is choking, pectoris, chest, right? It's pain that occurs when oxygen supply does not meet demand, resulting in cardiac ischemia. So this could be that the coronary artery is partially occluded, right? So as you see in this picture, I don't know how big it is on your screen, but the vessel is partially occluded, so less blood flow gets through there, and so especially with exertion, you get pain, right? And then usually at rest, it goes away. Now, if it's completely occluded, you would expect there also to be a pain, right? And that would be ischemia that would not resolve. Okay, so if there was a complete occlusion, that ischemia would not resolve without stent placement or intervention at the hospital. All right, so angina can be classified a few different ways. One of them is a stable angina. Okay, so stable angina is episodic chest discomfort. So it comes and it goes. It's usually predictable in its location, intensity, and duration, and it's caused by myocardial ischemia. Okay, so when we say predictable, okay, I walk to the bus stop every day. Every day I walk to the bus stop, I have chest pain. By the time I get to the bus stop, I sit down at the bus stop and my chest pain goes away. Okay. It's predictable. I exerted myself while I walked. I had pain, and now my pain is gone when I rest. Okay. Then I get off the bus and I walk home, and the same thing happens. It's predictable or stable. Okay. Some of the things that will trigger stable angina: emotional distress, extreme exposure to heat or cold, smoking, excessive alcohol consumption, and physical activity is a big one. Okay. Patients with chronic stable angina often take nitroglycerin to relieve symptoms, okay? So why do they have it prescribed? Because they have stable chest pain, okay? And then the ECG findings will usually show ST depression or inverted T waves, but will resolve when the demand is resolved, okay? So, or the demand is met. So if you had a patient, so the same patient that we talked about walking to the bus stop, right? That they walked to the bus stop and their EKG was normal, right? They started having chest pain. Let's say you had them hooked up to the cardiac monitor. You're walking with them to the bus stop. This is not realistic. You wouldn't actually do it. But when they started having chest pain, their EKG might start to look like this. So you notice that the ST segment is depressed. The T wave is inverted, okay? We sit down, the pain goes away. And when that pain goes away, they're usually back to this, okay? But in a lot of cases, patients with known stable angina are not calling 911, and if they've rested and it's gone away, you're not going to see this finding on an EKG, on your EKG. It's very unlikely at that point that you would have that finding. Right? You also have unstable angina. This is more serious than your stable angina. So it's characterized by changes in the frequency, severity, and duration of pain and other symptoms. So we'll go back to our patient that we just talked about going to the bus stop. So he says, every time I go to the bus stop, I have pain. When I sit down, it goes away. Today, though, I had pain, and it didn't go away. I took a nitro, and I still had pain. I took a second nitro, I still had pain. Now I've called 911, okay? So now that patient who walked to the bus stop, yesterday they had stable angina. Today they have unstable angina because the characteristics of that pain have changed, right? And it's not predictable anymore. So unstable angina is considered unpredictable, okay? All right. Know that unstable angina, the pain may not be relieved by rest or medications, right? So usually our friend, our scenario guy, right? He has the pain that goes away with rest. This time it wasn't relieved with rest or medications, and he called 911. Some of the other names that you may hear for this, right? Pre-infarction angina, right? Crescendo angina, pre-occlusive syndrome, referring to the vessel, right? So we don't have a total occlusion yet, but we are very close. So pre-occlusive syndrome, intermediate coronary syndrome, and then it is part of our acute coronary syndromes overall, so they may just refer to as ACS. Remember that these attacks of chest pain are often a warning sign of an impending MI. We would expect with unstable angina, they're still having pain, to find that ST depression T-wave inversion on the EKG. Variant angina, okay? Your variant angina is a type of angina caused by coronary artery vasospasms, okay? One of the things that's really, we associate with variant angina, cocaine or stimulant use or abuse, okay, are two really big ones that we associate with variant angina. So this is the 22, 23-year-old, right? Well, they could be older, but we'll say, generally 22, 23-year-olds, they're not having massive heart attacks. They can, but not usually, right? So they do a couple lines of cocaine, their blood pressure spikes, they get vasospasms of the coronary artery, right? And that artery, while it's spasmed, right? So artery, right? Spasms closed right here, and then maybe it's back open over here. This is a total occlusion. All right. Is it a permanent occlusion? Maybe not. Okay, but it is at this point a total occlusion. Okay, so they can occur at rest, or they can be brought on by emotional stress, exertion, or cold weather. They can also be brought on, again, cocaine is really commonly referred to for this. Okay, and so because there's a total occlusion, you would expect to find ST elevation on the EKG. Okay. Other names for this are Prince-Meadows angina and vasospastic angina. Okay. The EKG findings, transient ST elevation. So while they have that spasm, we find ST elevation. A lot of times these patients are taken to the cath lab, and then they go to do the cath, and voila, there's nothing in the vessels, and that's how they know. It's not. We would never say, oh, I think it's, variant angina or Prince-Meadows angina. I think it's vasospasm. We're going to treat it like they're having a heart attack, the same way we would treat every other patient that has ST elevation, and then take them to the hospital. But they only know when they cath them that the vessels were actually clear, and then it was actually a spasm rather than a clot. Okay. Symptoms may resolve on their own or with nitroglycerin administration. I'm going to add to this, if you have cocaine or stimulant use, you should probably call, if it's not in your standing orders, for benzodiazepine, because this, you should still treat, right, your aspirin, your nitro, but a benzodiazepine is going to help with the spasm itself. So you can call, if it's not a standing order for you, to give a benzodiazepine to relieve that spasm. You can also have microvascular angina. This is caused by constriction or spasm within the smallest coronary arteries, so the very tiny arteries, not the big major arteries. Okay, it often goes under-recognized and under-treated because when they do coronary angiography, they look at the vessels. It doesn't show any obstruction or spasm of the epicardial arteries or the big arteries that you see on the outside of the heart. This is more common in women, diabetics, and those patients with hypertension. The chest pain may be more intense and prolonged, and it may take longer to resolve. So we're talking the small vessels, and then, you could see how easily it'd be like, well, there's nothing wrong with you because our angiograph doesn't show anything, but actually they do have problems with the vessels themselves. These patients may also show ST segment depression on an EKG, but they may not as well. All right, so we said angina or chest pain is the leading symptom of acute MI. We're getting ready to talk about acute MI. So in an acute myocardial infarction, a portion of the cardiac muscle is deprived of blood flow long enough for the muscle to die. Okay, so I want to reinforce this to you, that ischemia is lack of oxygen. Okay, so AMI occurs when a portion of the cardiac muscle is deprived of coronary blood flow, which would mean that there's no oxygen delivered, right? Ischemia leads to injury, right? And if left untreated, that injury is going to lead to death, okay? Which is known as infarction, okay? I have an extra letter in there. Anyway, infarction, okay? Or necrosis. Okay. The location and size of MI depend on which coronary artery is blocked and where the blockage occurs. Okay, so if we think about your coronary arteries, right, you have your left main coronary artery, off of that comes your left anterior descending, and then your circumflex, which is going to go around to the back. If I have an occlusion, so this is going to be your left anterior descending, this is going to be your circumflex. If I have an occlusion way down here at the bottom of the left anterior descending, right, then less tissue is supplied by that at the very end. But if I occlude it way up here, this is a whole different kind of problem, okay? Just so you're aware, most infarctions involve the left ventricle, right? They can occur in the anterior, lateral, or septal walls. Those usually are going to involve occlusion in branches of the left main coronary artery. So back to our diagram up here, the left main coronary artery is the short artery where the left anterior descending and the circumflex branch from. Okay, the left anterior descending supplies the septal and anterior walls. The circumflex supplies the lateral walls. Okay, your inferior wall infarctions usually involve the right coronary artery. Okay, so the right coronary artery comes down the right side of the heart. It supplies the right atria, the right ventricle, and the inferior wall of the left ventricle as well. Okay. When we think about myocardial infarctions, we have to talk about subendocardial and transmural myocardial infarctions. Okay, so I'm going to talk about this area of the heart here. Okay, so you guys know that your coronary arteries are on the outside of the heart, right? And so the area that is furthest away from the coronaries is the endocardial layer of the heart, the area of the heart that is in contact with blood. Okay, so when you have a partial occlusion of a vessel, right? So let's say this vessel is partially occluded right here, okay? The area that's furthest away, this area over here, is going to be deprived of oxygen first, okay? So the subendocardial area, the inner layer of the muscle right under the endocardium, right, is going to be deprived first. So in a partial obstruction, you may have subendocardial damage, right? If I occlude this entire vessel, though, right, everything is going to be affected because there is now no flow through any of this area, and now everything supplied by that vessel is going to be without any oxygen. So it is affecting all the layers of the heart, and we call that transmural. Okay, so again, subendocardial, ischemic process affecting the inner layer of the muscle, right? Transmural, we have a complete occlusion. It's an infarction that extends through the entire ventricular wall. The infarction is surrounded by a ring of ischemic tissue, which tends to be electrically unstable, leading to cardiac dysrhythmias. Okay, so kind of coming over here to this side, this is what they're talking about, right? So that vessel is obstructed right here, right? You have the zone of infarction. This is the tissue that's dead. The zone of ischemia, or the zone of injury. The zone of injury, this area is going to die if we don't restore any blood flow. And then you have the zone of ischemia out here, right? And it's going to be electrically unstable and can lead to dysrhythmias. Okay. The longer the ischemic process goes on, the less likely it can be restored to normal function with reperfusion therapy, which is where they go in and they put a stent to open up the vessel. Or they may give medications to bust up clots. So on an EKG, I like this picture because it kind of gives you the different findings. I'm going to start with the picture on the right. So when we think about the myocardium, this is kind of what I was trying to show you on the last slide. You can have at the bottom, right, you can have subendocardial ischemia, right? Remember those coronaries are way out here. So if you had ischemia to that area, because you had a partial occlusion of a vessel, then you would expect to find not ST elevation, but usually ST depression. So I'm moving this way just so you know. And this is caused by, what did we say, a partial occlusion. Okay. If you have a complete occlusion of the vessel, right, everything that supplies that area, that is supplied by that vessel, is going to be affected. So you have, again, that zone of infarction, the area that's going to die, the zone of injury, and the zone of ischemia. This kind of MI is going to produce ST elevation on an EKG, and again, that is because you have formed a clot here and nothing is getting through. You have a transmural infarction caused by complete occlusion of the vessel. Okay, so types. And just so we're aware, because we haven't gotten this far in cardiology, if you ask me about STEMIs, I'm going to tell you they don't exist yet because we're not at that part of rhythm and 12-lead interpretation, but it makes sense to explain this to you now so that you have some kind of context for later. All right, so for your acute coronary syndromes, this is AHA. What AHA does is they say you run your 12-lead on your patient who you suspect has acute coronary syndrome. Maybe they have chest pain or some other symptom, and there's ST elevation or there's no ST elevation. If there's ST elevation, then that patient is having a STEMI, ST elevated myocardial infarction, and they need rapid transport to a cath lab for stent placement. If they have no ST elevation, then they might have a non-STEMI, or they could have unstable angina. Okay, so non-STEMI does not have ST elevation. How would we know? They draw labs, and they would have things like positive troponins. Okay. All right, so we're assessing the acute coronary syndrome patient or the patient having chest pain, right? You have to remember that time is muscle. So the patient care goals, identify quickly whether a STEMI, supposed to be an I in here, STEMI is present. If so, notify the medical facility ASAP. So we go in, we're taking care of this patient. Hey, sir, man, what's going on? Oh, I'm having the worst chest pain of my life. Okay, I'm doing my assessment. My partner's getting the 12-lead. It prints out. There's a big STEMI on the EKG. As soon as I see that, I'm getting on the radio and I'm saying, Cape Fear, this is medic 10. We're going to be en route with a 55-year-old male. Chief complaint, chest pain. Be advised, this is going to be a code STEMI. Patient has ST elevation in V1 through V4. His cardiologist is Dr. Bacon, and we have an ETA to you of 15 minutes. So quick notification, because what this does is this gets things moving at the hospital. So when you activate a STEMI alert at the, okay, or a code STEMI, they are paging the cardiologist and cath lab staff. And they have 30 minutes to respond. Okay, so the earlier you let the medical facility know, the quicker they're going to be en route. Okay, so the less time the patient's going to be waiting. Okay, you want to determine the onset of the time of symptoms. You want to monitor the patient's cardiac rhythm and vital signs, so we want to have them on continuous cardiac monitoring. You want to be prepared to provide CPR and defibrillation if needed, so put pads on these patients, make sure you have IV access, right? And take a rider if you have one, because patients who are having heart attacks could go into cardiac arrest, and doing CPR all by yourself, number one, it sucks. Number two, it's not going to be good quality. So take a rider if you have one available, right? Administer appropriate medication, so things like aspirin, nitro, right, would be appropriate. The dosing for aspirin is 162 to 325 milligrams of ASA, right? Nitro, okay, and then you may also give morphine or fentanyl. Oxygen should only be given if their saturations are under 90. We're titrating only to an O2 sat of 90. Okay, so titrate O2 to 90%. Okay, and then transport to an appropriate facility. What type of facility? A PCI center, somewhere that can do a cath. So PCI stands for percutaneous coronary intervention. All right, some of the symptoms for ACS. Okay, we've all been to this patient. The patient clutching their chest, that is called Levine sign. Okay, so it's a universal sign for chest pain, that clutching of the chest, right? So some of the major symptoms going to be chest discomfort, right? Pain beneath the sternum. It's often described as heavy, squeezing, crushing, or tight. Sometimes it radiates to the neck, the jaw, upper back, or the epigastrum. It is more likely to be dull than sharp, like it's not usually point tenderness, right? It's unaffected by deep inspiration, movement, or position. Okay, so it's not going to change with those things. It may or may not be relieved by nitrates or rest, okay, and they may demonstrate Levine sign. A lot of patients, many patients confuse pain for GERD, right, because of the location of the pain. So if a patient has GERD, just know that that could be, or they think they're having heartburn, that could also be a sign of an MI. Remember that not everybody has chest pain. You should know thy equivalents, okay, or angina equivalents, so things that we should be suspicious for acute coronary syndrome, okay. Atypical or unusual symptoms are more common in women, older adults, and diabetics, okay. And I would like you to note this right here, that up to 20% of patients with STEMI do not present with chest pain or discomfort. So that's 1 in 5. Research shows that more than 25% of patients with STEMI who present without chest pain do not receive pre-hospital EKGs. So my rule for EKGs is a complaint that is nose, or basically the head, to navel, the belly, front or back, gets a 12 lead, and then depending on the suspicion of, the index of suspicion that I think they're having ACS is going to depend on the order in which I do that. Doesn't mean I'm doing it first. It just means at some point in their care, if they have a nose to navel complaint, they get a 12 lead. Okay, so again, 25% of patients with STEMI who present without chest pain do not receive pre-hospital EKGs. This should be a never event, okay, and have significantly longer EMS to balloon times, which is the definitive care for STEMI. To avoid delays in reperfusion when caring for patients with a possible acute coronary syndrome, keep in mind the concept of atypical presentations and anginal equivalents. When in doubt, obtain a 12-lead EKG. It's not an invasive procedure. Okay. So this brings us to what are angina equivalents. So here they are: abdominal pain, acute changes in mental status. Why? Decreased perfusion to the brain, usually because of decreased perfusion to the heart, because of decreased cardiac output. Diaphoresis, dizziness, dyspnea, dysrhythmias, okay, epigastric pain, right? Fatigue, generalized weakness, indigestion or heartburn, okay? Isolated arm or jaw pain, especially in the absence of any trauma. Lightheadedness, palpitations, restlessness, syncope or near syncope. Remember this? This is cardiac until proven otherwise. Syncope is cardiac until proven otherwise. And then unexplained nausea or vomiting. So patient calls, have abdominal pain, nausea, vomiting. They haven't been around anybody that's been sick. The patient and their spouse had the same meal for dinner, right? They called after dinner. The husband is complaining of abdominal pain, nausea, vomiting. The wife is not, right? We should be looking at that and going, that doesn't really necessarily fit like a sudden onset of food poisoning, right? So unexplained nausea, vomiting. When you're looking at the patient with acute coronary syndrome, you're going to look at their general appearance. Oftentimes they're anxious, they're scared. They may obviously be in pain, but again, remember, they don't always have pain. Poor perfusion creates confusion, so if they have decreased mental status because of poor perfusion, they may also be confused. Their skin may be pale, cool, clammy. It also may be gray. You want to make sure that we're getting vital signs, right? You may have pulse abnormalities, blood pressure abnormalities, and even changes in their respiratory rate. And then they may have signs of heart failure, because the heart is the pump, and with acute coronary syndrome or a heart attack happening, right, you would expect that at some point that pump function would fail, and that would lead to signs of left or right-sided heart failure. Left-sided heart failure presents with crackles and sometimes wheezing. Right-sided heart failure presents with JVD, pedal edema, or sacral edema, Usually this one is first because of its location. So JVD usually presents first, right, because it's close to the heart, where the feet and the sacrum are further away. So in an acute heart attack, I'm having crushing chest pain, and I immediately call 911. I might not have pedal or sacral edema, right, but I may have JVD if I've got right-sided heart failure. Some of your differentials, okay, so differentials for acute coronary syndrome, some of them these are broken down by diseases, but cardiovascular disease, they may have an aneurysm, aortic dissection. They could be having ischemia rather than actual infarction. They could have myocarditis or pericarditis, which are inflammatory conditions that affect the muscle layer and then the outer layer of the heart. It could be that they're having chest pain for GI causes, right? So cholecystitis or an inflamed gallbladder. Esophageal spasms would hurt. GERD, right? A hiatal hernia, indigestion, pancreatitis, or an ulcer. Those could all cause chest pain, right? Some of the musculoskeletal causes: chest wall trauma, a chest wall tumor, which you're probably not going to diagnose in the field, costochondritis, which is inflammation of the costal muscles, right, or the rib areas, right, and then intercostal muscle cramps. They could also have respiratory diseases that cause, or respiratory causes that lead to chest pain. So pleurisy, which is inflammation of the pleural lining, pneumonia, pneumothorax, a PE or a blood clot that has moved into the lungs, which is really bad, and then any kind of respiratory infection. We also see chest pain with things like anxiety and panic disorders, and also with herpes zoster, which is shingles. If you don't look, you will not find this. It should have a rash if they have herpes zoster or shingles. Okay. Your management of your patient. Okay, patients with STEMI are most likely to benefit from reperfusion therapy. This is mechanical or pharmacological restoration of blood flow. Okay, your percutaneous coronary intervention. This is mechanical restoration. Okay, they go in, they place a stent in the artery, which opens up the artery to restore blood flow. The goal for this is first medical contact, that's your FMC, to balloon, the time that the vessel is reopened, is less than 90 minutes, okay? So things that we need to be worried about, short scene times, right? Rapid transport for patients who are having STEMI. Other things that they can do are fibrinolysis. Lysis to cut or break down fibrin, the stuff that holds the clot together, right? And this is going to be your pharmacological restoration. And this is, again, going to dissolve that blood clot. The goal for this is door to needle, right? So this is the ED, where we'll bring the patient into the ED to the time they start the fibrinolytics through the IV in 30 minutes. Okay? Don't be confused about the role of the pre-hospital provider. Acute coronary syndrome is not something you can fix. You cannot fix this, not, okay? What your role is to rapidly identify that this is happening, right? We get a rapid EKG, we've identified STEMI, we're gonna keep the patient at rest, right? We're gonna rapidly activate resources. In this case, we're gonna get on the radio and say, hey, you, this is me. We're bringing in a code STEMI, right? ETA 10 minutes. We're going to provide rapid transport safely, and then we're going to support the patient emotionally, pharmacologically, and sometimes mechanically, which is our CPR that you're seeing over here. Okay. All right, this is the algorithm for acute coronary syndrome. Okay, so EMS assessment and care and pre-hospital preparation is up here at the top. Okay, so if you have symptoms suggestive of cardiac ischemia or infarction, this is how you get to this algorithm. So we're going to assess our ABCs. We're going to be prepared to provide CPR and defibrillation. We're going to administer aspirin. We're going to consider nitroglycerin. I told you guys your target's 90% for that. We're going to give nitro if appropriate and morphine if needed. We're going to obtain a 12-lead EKG. If ST elevation is present, we're going to notify the receiving hospital with the radio. We're going to transmit if available and provide the interpretation. We want to note the time of onset and first medical contact because they're being evaluated on that first medical contact to balloon time. Okay. If considering, so notify the hospital, right? Provide the pre-hospital notification of the notified hospital should mobilize the resources to respond to the STEMI. They're going to page out the cath lab team and the cardiologist. If considering pre-hospital fibrinolytics, then use the fibrinolytic checklist. Okay, so over here, right, once they get to the hospital, right, they're going to activate they're going to activate the STEMI team upon EMS notification. So when you get on the radio, they're going to do that. When they get to the patient, right, they're going to assess ABCs. They're going to provide oxygen if needed. They're going to establish IVs if you have not done that already. They're going to perform a history physical exam. They're going to review the fibrinolytic checklist. They're going to draw labs to include cardiac markers and coagulation studies. They're going to get a chest x-ray as long as it does not delay transport to the cath lab. Okay, and then generalized treatment. Okay, if the oxygen saturation, you're going to do this too, by the way, not just at the hospital, but if the oxygen saturation is less than 90%, you're going to start oxygen at 4 liters and you're going to titrate up as needed to get it to that. You're going to provide aspirin 162 to 325 if it's not already been given by EMS, which again, like I told you, you're going to do that. And then nitroglycerin if needed sublingually. Okay, morphine if the pain's not relieved by nitro, and then they can consider some other drugs. Okay, this was what I was telling you about the EKG interpretation. So on the EKG interpretation, you either have STEMI, right, where they're going to take the patient to the cath lab, or you have non-STEMI, right? And this is where the hospital is going to work this algorithm where they're either going to go to the cath lab, draw labs, and then potentially go to the cath lab and go from there. Okay. All right. So to expand on our management of the acute coronary patient, we want to place the patient at physical and emotional rest. We do not have them walk, so do not make them walk. Okay, no walking, no exertion. Okay, we also don't want to be like, oh my God, you're having a heart attack, because that's going to scare the crap out of the patient. Stress is going to lead to an increase in the fight or flight response, catecholamine release, which is going to put more demand on the heart than they need. We want to obtain vital signs and make sure that we're doing cardiac monitoring. We want vital signs every 5 minutes. We want to be prepared to treat any arrhythmias. We want to administer aspirin and oxygen. The dose again for that aspirin, 162 to 325. Oxygen target is 90%, unless they have respiratory distress, in which case you can provide more than just nasal cannula to get you to 90%. You want to obtain the 12 lead, and then you want to do it again. So I've seen in several cases where the first EKG, right, on scene was normal, right? And then 15 minutes later en route, the second EKG is a STEMI. Okay, so we want, just because the first one is normal or non-diagnostic, right, doesn't mean that the next one won't be abnormal. So serial EKGs is going to be important, okay? We're going to call it a STEMI, and there's a little more to this because you guys haven't had all the STEMI lectures, or all the 12-lead interpretation lectures, but if you have ST elevation in 2 or more contiguous leads, or leads that look at the same part of the heart, or a new or suspected new left bundle branch block, it's going to be called an NSTEMI if there's ST depression of 0.5 millimeters or more in 2 or more leads. And then any other EKG is non-diagnostic. There's no such thing as a normal EKG because we can't say that the patient is definitively not having a heart attack just because the 12 lead doesn't have any abnormality that we can identify. If there is a STEMI present, the scene time should be 10 minutes or less. Again, alert that hospital immediately to get things moving, and then complete your fibrinolytic checklist. Okay. If you guys are doing fibrinolytic checklist, you're going to find it within your protocol. Okay, but basically the fibrinolytic checklist is this part right here. You're going to look to see if there's a contraindication to fibrinolytics. So if the patient has any of the following, they could have a contraindication. So blood pressure, their systolic blood pressure is over 180 to 200, diastolic greater than 100 to 110, or if there's a right versus left arm blood pressure difference more than 15 millimeters of mercury. Stroke, for stroke patients, if longer than 3 hours or shorter than 3 months ago. If they've had trauma, blood loss, or surgery, significant closed head facial trauma within the previous 3 months, major trauma, surgery, including laser surgery or GI/GU bleeding within the previous 2 to 4 weeks, bleeding or clotting problems, or they're on blood thinners, and then other things, serious systemic diseases, so advanced cancer, severe liver disease, kidney disease, things like that. Any history of intracranial hemorrhage or bleeding in the brain, and pregnancy. So if the patient has no contraindication, transport to a primary PCI facility. If the patient has a contraindication, consider transport to a primary PCI facility. And then a potential contraindication suggests that fibrinolytic therapy is high risk for that patient. Ultimately, whether or not they give fibrinolytics is going to be up to the physician. We're probably not starting those in the pre-hospital setting, depending on where you work. All right, you want to provide pain relief, so nitroglycerin. What nitroglycerin does is it decreases preload. Okay, so it's going to decrease preload, and because there's less blood that returns to the heart, you're going to have less work with contractility, which is going to reduce myocardial oxygen demand and help increase flow because we've reduced the demand. It's going to be contraindicated for patients with an initial blood pressure less than 90 or patients who've used phosphodiesterase inhibitors in the last 48 hours. Those are your erectile dysfunction drugs. Use extreme caution in patients with inferior STEMI or suspected right ventricular infarction because those are preload dependent. And the big thing is going to be this, right? The suspected right ventricular infarction. You don't want to decrease preload if they already have a preload problem, which we'll talk more about when we talk about heart failure. We want to give morphine or fentanyl if the pain is not relieved by nitroglycerin following your protocols and as long as the vitals are stable. Morphine tends to drop blood pressure a little bit more than fentanyl does. We want to transport the patient and take a rider with you. Why? Because nobody wants to do CPR by themselves, and the patient doesn't want you to do CPR by yourself either, because, surprise, surprise, it's not going to be very effective when you do 10 minutes of CPR as a single provider. Okay, you want to put pads on the patient. You want to start 2 IVs if possible. You want to shave the patient's wrist and groin area, and this is because that is where they go in, usually in the right wrist, but to put in the stent, go through the wrist, and then secondarily they may use the groin, and then complete that fibrinolytic chest pain. What do you do if the patient does not want to be transported, right? Scary, okay? This is considered a high-risk refusal. You should get medical control involved. The outcome could be fatal. The patient needs to know that, okay? So we want to do everything we can to get the patient to go voluntarily. Okay? And that is the end of our lecture on acute coronary syndromes. The next lecture will be on heart failure coming up.